we're using all of these drugs together, it's getting super expensive. Lenalidomide, carfilzomib, daratumumab are all very expensive drugs. Do you see a day in sight, Raphael, where we might consider stopping therapy and not continuing it forever?
So I myself don't see me making decisions ever based on that. And the reason for that is that it's not to say that we should be
well, I'm not saying you're making decisions based on the cost. I'm saying, do you think there's a time where the cost can come down because we can stop the treatment because it's as effective?
So of course, and I think that's the point that Andrew made before. It's incredibly important. I do see a future where we're going to have a fixed duration of treatment that will result in MRD negative in a substantial fraction of patients, that would allow the treatment to be shorter and ultimately to be cheaper. And then once these drugs become generic in the future, all of them will be incredibly cheap. To think about the 2000s when the first wave of long-term sustained remissions in myeloma came to be.
We already have evidence that that is actually happening because to some extent French IFM 2009 study had provided a lot of data. Not only that transplant is still needed in novel era, which I completely value as the most important outcome of this study, but we mentioned that briefly in patients who have been treated with or without transplant, but achieve MRD negative status and CR. When they looked at their survival curves, they were very comparable, not statistically different. So that guides us now that achieving this level of response, no matter what you do, to getting there eventually gives you that chance. And the probability of relapse for this patient was relatively low, and I think we can actually narrow that gap completely to 10%.
Mary, do patients understand minimal residual disease and what its implications are, or is that just a bridge too far for them just now?
No, they're beginning to, and we certainly are concentrating on educating patients in that area because, we really feel like it's a necessary development in the field to be able to use MRD as a surrogate endpoint in clinical trials and to help guide treatment decisions. So we're trying to prepare them as best we can to understand what those results mean.
Are you doing much MRD testing, Raphael?
Yes, I am. So there's two scenarios where I do it. Prognostic at day 100 post-stem cell, and I do it in patients who have long-term sustained CRs on therapy to have the conversation about discontinuation of therapy.
And you, Andres?
We have as a standard of care our own flow-based MRD, which is aspiring to be Euroflow level, 10 to minus 5. We are tuning it up, but for the most part because we run all of these patients who are on trials also simultaneously.
So you're not using molecular
MRD testing? We are. Most of our patients are on clinical trials, so I actually have for most of our patients 2 results, both flow and next-gene sequencing. There is about 10-15% difference that we will have patient who is MRD negative by flow will be still positive by next-gene sequencing. We are about to launch commercial use of that test, which is now FDA approved. So we will be using it fairly regularly. As Raphael, because so many patients in our treatment achieve complete response on long-term maintenance, we believe that at some point we will learn that patient who has sustained MRD negativity for a year or 2 or more will be able to be approaching this question, can we stop or not? So we in a way are trying to predict that moment by collecting the data already. So I yearly check patients in complete response and we have this information.
So if I could just expand on that and walk through the logic. If a patient is going to get maintenance, myeloma experts will disagree whether they can get 1, 2 years or indefinite. And all of those answers are correct by current standards. So I think it's perfectly fine to discontinue therapy in someone who has had a sustained CR with MRD negativity at 2 or 3 years. The person could have stopped therapy even without doing the testing, but it just adds information. So if someone is struggling with a little bit of toxicity and they're wondering whether they should continue or not, and they're MRD positive, maybe they'll want to try for a little bit longer of therapy. On the other hand, if someone has a CR but they're unsure about stopping therapy and they get an MRD negative result at 3 years, I think maybe the person is going to be a little bit more confident. There's just one more bit of information that comes into the bedside to make decisions.
So to be the devil's advocate here, there's really no plateau in the curve, even if you're MRD negative. The people are still relapsing. So why are you so confident they can use that as a...
Well, I think because the argument, again, goes to how long is the standard duration of maintenance therapy. And if there was no plateau, then you would say no one should only get 1 or 2 years, right? Now, I would counter that the Spanish group, even before we had maintenance or MRD, does show that CR patients can go into that plateau. Now, their subsequent publication doesn't show that plateau, but I think that study that was published in Blood in 2011 does show, like the studies have shown from the University of Arkansas, and like we see anecdotally in our clinics, there's a small subset of patients, hopefully growing, that will have sustained CRs and never again require intensive therapy for myeloma.
Mary, when I was at the hematology meeting last December, somebody coined the phrase MRD anxiety, which was we're doing all this MRD testing.
I've seen that in patients.
Yeah, I was going to ask you, are you seeing that in patients?
I have seen patients who have called and said, "Oh no, I'm MRD positive,"
Yes.
and they're handed a number and they have no understanding of what that means.
And then they track it over time. And
Yes, yes.
I've noticed the same thing. And in fact, it makes me anxious as a physician. Like, it's almost a curse, because it used to be, wow, you're doing really great. Look at your bone marrow's normal, your blood's normal. And now you're like, oh, sorry, you've got MRD positive disease.
So, but I wanted to ask a question too. I mean, so as we're talking about what's happening in your center, in your center, in your center, which wouldn't necessarily be considered community care centers, what is happening in the community as far as MRD?
Well, what I've heard the community doctors saying is they're not performing MRD. They understand it. They understand the value, but I think there's not enough evidence for them to start adopting it at this point. And in fact, there are even some of our academic colleagues, I think, who feel it's being oversold and it's not to be used for decision making. I know I heard Dr. Barloghi tell me that one day, for example.
And probably rightly so, because I don't think we have data at the moment, and your comment about no development of tail of the curve is a good argument that we haven't gotten there. But we haven't really addressed one important issue. MRD is a big basket which we are sometimes forgetting to maybe define a little better. There is different layer of MRD. Any MRD predicts or is able to help us what the outcome will be. So you achieve MRD negativity, probability of staying longer in remission is essentially indicated. But if you have MRD negativity, say 10 to minus 4, 10 to minus 5, it doesn't mean exactly the same as 10 to minus 6. Right. And probably we need to go even deeper, in my personal opinion, 10 to minus 7 if achievable. So that's
depressing.
eventually.
When you look at mass spectrometry, everybody's still positive, so it's kind
Correct.
of depressing to go there.